Uh, so can we start, sir? Ravi, sir?
Are you able to hear me at all?
Yes, sir. Yes, sir.
Yes. Would you be able to share your screen, sir?
Hello.
Yes, sir.
Hello. Yeah, you are audible, sir.
Excellent. And can you see me as well?
Yeah,
Little
you can see.
little bit dim.
It is a bit dim. Hang on.
Yeah.
Let me switch on the lights.
Please,
Oh,
sir.
yes, sir. That will be great. You have lovely scenery outside.
Well, you asked me to close it.
No, actually everything.
Is that any better?
Better.
Much better.
Yes. So, sir, I'm starting. So
Yeah.
I just have a just brief agenda of the today's meeting. I am Dr. Gunadhar Padi, consultant intensivist and coordinator, Apollo Hospital, Navi Mumbai. So basically, these programs are for our DNB students. Every week we conduct, and I thanks all the panelists and all the delegates who have joined, and special thanks to Dr. Ravi Kumar sir. So first, sir, we'll have your lecture for almost around 45 minutes, and followed by a half an hour discussion from all the delegates and our DNB students who are there in the today's meeting, and then we'll close the meeting, sir. So I would like to share your slides, sir. By the time I'll just introduce the other panelists so that the meeting can be started. Thank you. So by the time Ravi sir is sharing his slides, so just let me introduce my other panelists and the faculties of the today's meeting. My colleague Dr. Akhilesh from Apollo Hospital, Mumbai, consultant intensivist, and he and myself will moderate this session. And we have today other eminent panelists with us, like Dr. Deepak Govil. Sir needs no introduction. Consultant in charge, head of the department. Particularly, sir has done a lot of these cases of liver transplantation and CRRTs, the bridging therapies, and I really appreciate sir has spent his time and joined with us for some knowledge to be disseminated to our students. And welcome, sir, Deepak Govil, sir.
Thank you very much for invitation.
Thank you, sir. With us, my co-colleague, Dr. Divya. Dr. Divya Kukian is working as a consultant intensivist at Apollo Hospital, Navi Mumbai. And she has also done handled a lot of this transplant patients, particularly the liver transplant patients. And she will be joining the session today. Welcome, Dr. Divya.
Thank you. Thank you.
And with panelist, Dr. Akira Rajakumar. She is also one of the leading transplant physician intensivist in Chennai. And with this, let's start the program of today. And I'll hand over the mic to Akhilesh for another brief introduction of Dr. Akira, so that the session can be started.
Hi, welcome, Dr. Akila. I mean, Dr. Akila is, trained in liver transplants, and she has been actively involved in, liver failure clinics also, and liver failure ICUs. She has been trained in London, and then she has come and joined here at the Rela Institute of Hepatology and Transplantation Services. And I really sincerely thank you for your acceptance. With such a short notice, you have accepted, and really thankful to you. And hopefully, the students will be enlightened with the knowledge that you will be disseminating today. Another panelist that we have today is Dr. Suresh Vasant. So, Dr. Suresh Vasant is anesthetist and intensivist in liver transplantation at the Queen's Hospital, London. And today we have the opportunity to have him with us on panel discussion. Welcome, Dr. Suresh Vasant. Dr. Suresh Vasant seems to be a little busy with his transplant, which is ongoing, but he will be joining us shortly. With this introduction, I hope this program will be greatly useful to all the students and the consultants in the field of intensive care. And I would request Dr. Ravi Kumar to initiate the discussion and the presentation today. Over to you, Dr. Ravi Kumar, sir. Thank you very much.
Sir, before you start the presentation, we just, because a lot of our trainees are new, sir, I'll introduce you in a short. Basically, sir is working in, he is a consultant, intensivist, transplant physician, anesthesiologist, and he is working as a intensivist, transplant intensivist in Surrey and Sussex NHS Trust Hospital and Guy's and St. Thomas University Hospital, sir. And I will just like to have a brief introduction, sir, and then begin the talk, sir. Thank you, sir.
Thanks very much for the invite. And it is a beautiful, beautiful British summer at the moment here, I have to say. It doesn't happen that often. So my name is Ravi Kumar. With regards to introduction, I trained in India, in Delhi. I did my MD medicine and MD anesthetics back home, and then I trained here again in medicine and anesthetics and ICU. I did a PhD here in hepatobiliary diseases and fellowships here in liver and pancreas diseases and transplants. And I work as a general intensive care consultant in Surrey and Sussex with inputs to the St. Thomas's Hospital off and on, and hold an honorary consultancy there. My interest, well, obviously needless to say with that much of time, has been hepatobiliary critical care patients over the years. I have been an EDIC examiner for just close to 17 years now. We run the London Center, and I've chaired the exams for about 5 years, gave up quite a few years ago. So yeah, that's my background. I am a jobbing intensivist. I see patients every single day of my life.
Thanks, sir. So,
You're happy to start?
Yes, sir.
Okay, so I was asked to talk about the changing paradigm of acute decompensated or compensated liver failure as time goes on. And when I was asked to do this talk, and I'm very grateful that you did ask me actually, I was not entirely clear about the audience I'll have, because I thought, well, there might be established clinicians listening to this talk. There could be students, there could be exam going students. There may be some medical students, I don't know, I'm not sure. And obviously in any liver talk, if you see Deepak's name there, you always get a bit unsettled, because I don't think as on date in this world anybody does more liver transplants than Deepak's unit, I have to say. So yeah, so slightly unsettling, but we'll share our experiences, what we do and what we do on the ground reality. And how I plan to go about this is, a lot has changed about the pathophysiology of acute liver failure over the years. And we will talk about that. It might be slightly boring to established people who already know this, but certain aspects of that are quite important with regards to, I can only talk about the European diploma in intensive care exams. I can't talk about the Indian exam systems. So if it does get boring, I apologize, but we'll try to make it interesting and we'll see how it goes. So on that note, we'll start with some stats, and if you want, you're recording this talk anyway, but if you want a copy of this presentation, I would be more than delighted to share it with you. Okay, let me see if I can change this. So let's talk about some some stats, and we'll start with Britain first. There has been a 400% increase of liver deaths due to liver diseases in the last 50 years. So 400, no other disease has increased by this rate. And still the awareness and education of people is general population, which literate British population is so low that even just about 5% people consider that to be a worry. If you have chest pain, you run to the hospital within the first half an hour. And in all fairness, the system responds quite rapidly as well. However, if you start to get yellow, you sit there and you mull over the problem. It will all get better, and let it linger. 94% of British adults think that your life has gone out of track and you've lost control over life if you drink alcohol and subsequently get a disease to alcohol. So the social stigma is very badly attached. And actually, talking about the social stigma, we did an audit which was published in JICS about 7 years ago now, and we were looking at prejudice of intensivists for admitting acute decompensated alcoholic liver diseases to intensive care in their first admission. And the results were quite telling, really, because there was definitely an element of bias against these people. I hope by end of this talk you will understand that actually these people do deserve a chance, and if we manage them properly, they do well. If you look at the community, there are a lot of people working in the community, irrespective of which country they live in, with compensated cirrhosis, and they do have a life. Okay, yes, their lifespan is certainly shortened, and their tipping points are certainly lower, but they do have a life. Okay. Moving on. The problem with liver disease in particular is it is essentially a disease of the young. It takes away working life. 62,000 years of working life are lost every year in Britain as on date, secondary to alcoholic cirrhosis and related deaths. 90% of liver diseases happen mainly due to alcohol, obesity, and viral hepatitis. And increasingly, the viral hepatitis is being seen more in expat population, and the proportion of alcohol seems to be rising by the day. So these are all preventable, in all honesty. The vaccination program and the awareness of hepatitis is much more higher than it used to be about 20 years ago when I started here. So on and around, as per the British Liver Trust data, and this is about 6 months old, we do about 1,000 transplants a year in this country. Most of them are cadaveric. And at any one time, there are 350 people waiting. So we have phenomenal number of deaths from end-stage liver disease for people who actually can't get an organ. So it is kind of a dire situation and seems to be getting worse. Okay, I'll finish with this, won't bore you too much with this. Alcohol per se is 60% of all liver diseases causing hospital admissions and subsequent morbidity and mortality. About 8,000 people die from this every year. Mind you, we are only a country of 60 million. So that is a huge number, seems to be rising by the day. And needless to say, this is no brainer or rocket science, really, that the more deprived you are, the higher you are likely to die from alcoholic liver diseases. I practice in Surrey, which is one of the most affluent parts of UK. Comes up in top 5 affluent parts in the UK. We see a lot of alcohol here. And what I've started calling them is, so if you look at my geographical area, it is full of bankers and very wealthy businessmen and hedge fund owners, really. And we still see a lot of alcohol in them. I call them cryptic alcoholics, right? And the reason I call them cryptic alcoholics is, if you ask them, they won't say they are addicted, or they won't say alcohol is a problem. But when you look at them, you know by the bedside that, dude, you are drinking a lot, aren't you? And when you actually delve into their history, they will say to you, yes, I do drink a bottle of wine with dinner every night. And then you say, what when the friends come over? He say, oh, we might go up to 3 or 4 bottles. And what about weekends? Oh, I might go to my house in France, and we will have a good weekend. So I call them cryptic alcoholics. They don't die as much as people from the deprived area, and that's probably because they are well nourished and they do look after themselves well. But alcohol does remain a problem. Costs us about 7 billion in productivity, and about just under 4 billion in direct costs every year. This is our data, and this is from the last census. If you look at our mortality, this is the most worrying factor. You see the trajectory of how the deaths from liver diseases have gone up in the last 50 years. Whereas what is more worrying is the trend of deaths from other diseases seems to be either stabilizing or consistently going down. You could argue that they are more glamorous diseases, and more resources and research has gone into it, and the government intent has gone into it as well. So you could argue a case of a bit of a bias there as well, as I was saying earlier. This is the international data with regards to the top figure. It may not be very clear, but essentially the top figure is about the mortality of males and females around the world. And you see Central Asia tops that list. But if you see Southeast Asia isn't that far. The big difference between Southeast Asia and Central Asia there is the gender bias seems to be more, i.e. There may be a preponderance of males drinking more than females. And I'll come to this in a minute because it is quite significant. The bottom graph is about the risk of compensations and decompensations and subsequent death in different genders. Female tends to decompensate more as compared to males. So the absolute numbers are still higher for males, but the preponderance of female decompensation seems to be getting more. And this is a particularly worrying factor, especially metropolitan cities anywhere in the world. It does not have to be the Western world. You go anywhere in the world, and if you look at the data that is coming out, is the level of female drinking is massively increasing. And the sad part of it is the incidence of smoking along with alcohol in females seems to be going up. My colleagues in the panel might disagree with me on that one, but we'll take it when we come to the question time later. This is again a similar kind of graph, so I'll skip this one, and essentially I've said what I wanted to say in the previous slide on this one. How about the Indian data? Now, the problem with Indian data is it is very robustly collected, but it is not, what we don't know is what is the geographical expanse of this data, because I believe talking to a lot of people is a lot of lot of alcohol-related mortality and morbidity may not be reported appropriately from the rural parts of India, and this data, if you look at it, what is worrying here about India is that the incidence of cirrhosis and mortality, if you look at this particular graph, seems to be static. It does not seem to be changing. And it's not to do with definitive treatment or transplant or anything like that. It may be because of not much effort going into primary or secondary prevention there. So, and if you look at the yearly data here, I don't know how clear the graph is. Can you actually see it, by the way? Are you able to see the graph? Or
yeah, we are able to see that, yeah.
If you look at the data, the green bar for cirrhosis, you see it almost seems to have doubled, especially in this graph. If you see from even in the last 20 years, it seems to be consistently going up. Right, on that cheery note, let's talk about the liver. Okay. It is indeed a fascinating organ, without a doubt. It may not be as glamorous as the heart or certain other organs, but it certainly is a fascinating organ. It forms about 2% of the general body mass, and in a normal physiologic adult liver, about 25% of the blood comes from the hepatic artery, which supplies 75% of the oxygenated blood, whereas the remaining 3/4 come from the portal vein, which only actually supplies about 25–30% of the oxygenated blood that the liver needs. At any one point, the liver is receiving about a quarter of your total cardiac output or total blood volume that circulates every single minute. And if you get cirrhotic, or if you start to decompensate, that 25% can go to 40% and sometimes up to 60%. So fascinating amount of cardiac output may be going through your liver every minute as things go wrong. So what really happens? We'll move on to pathophysiology now in a minute. Talking about mortality, and as things go on, and as medicine develops and overall global care of every clinical disease develops over a period of time, acute decompensation in first presentation in mortality within the first 90 days is high. It is still 15%, but not massively high. Repeated presentation, not a surprise, cause a rising mortality. So if you have a ACLF, which is acute and chronic liver failure, with each subsequent presentation, your risk of death rises by 50%. In 40% of the time, you will always get these patients who will have a telltale signs of liver failure, but you will not be able to pinpoint a cause. Some people call it cryptogenic liver failure, some people call it idiopathic liver failure, but surprisingly enough, acute fulminant liver failure from things like which were standard exam questions like the paracetamol poisoning, they seem to be decreasing. And if you look at the King's data, King's College in London data, we hardly now transplant patients with paracetamol poisoning, hardly ever do it. And that is simply not because we are not getting cases. It's just our management at the time of presentation is pretty good. And all they need is supportive management, and the system clears out. So traditionally, acute liver failure was considered as a circulatory disorder, because you read and look at historical textbooks and papers, and all it was there is portal hypertension secondary to splanchnic vasodilation, and hence hence the portal pressure rises and rises and rises till a varices burst, and the patient has hematemesis, and then he gets a SBP and subsequently causes death. That was the traditional teaching, and that is still holds good. That still indeed holds good, but it is not the only cause. So if you think about the definition of cirrhosis, the two caveats to or the two essential criteria for being cirrhotic is you need some degree of nodularity and you need some degree of fibrosis. What does that do? What it does is it increases the fibrosis, increases the intrahepatic vascular resistance, and the massive liver is a massive reservoir of nitric oxide and nitric oxide like vasodilator products. So it reduces the splanchnic vascular resistance. Now that happens probably because of myelofibroblast, and we'll talk about it later. They tend to squeeze the hepatocytes a bit too much, and there seems to be a surge and of these vasodilators causing a drop in vascular resistance. So what then happens is obviously your effective blood volume decreases because the system is so vasodilated, and that manifests as hypotension. The classical finding of a liver failure patient by the bedside, as you know, is rapid bounding pulses who look, the patient looks quite flushed initially, if you can make it out. A vasoconstricted liver patient is bad news. They will probably die irrespective of what you do. And then what also happens is because of the toxins release and all that, and constant release of particularly IL-6 within the system, these patients tend to get a cardiomyopathy, which causes a diastolic dysfunction in these patients, causing diastolic failures, and hence the cirrhotic cardiomyopathy. Body does try to compensate for it. It really does it particularly well, and it's the standard physiology. If you have any kind of hypovolemic shock, what happens in physiology? Your renin system gets activated, you have a high sympathetic drive, your vasopressin systems get activated. What happens as a consequence then is mainly because of the AVP and the RAA system, the body tries to retain water. And as a consequence, with the aim of increasing the blood volume. But what happens as a side effect or collateral damage to that is it causes significant renal vasoconstriction. And then what happens is eventually the nitric oxide stores are finite to vasodilate the system, including the kidney, and glutathione synthetase activity does get exhausted. It is time limited and concentration limited. Let's talk about portal hypertension a bit. I won't go into why portal hypertension develops, and the basic physiology is in medical textbooks, and essentially it is increasing resistance and increasing resistance and increasing flow through the system and bypassing of the collaterals. But what is increasingly coming out now, and with the better ultrasound skills that intensivists have across the world, is increased importance or recognition of hepatic portal vein gradient or hepatic pressure vein gradient. And it is now a given. It is a bit like measuring ejection fraction. It is a very steep learning curve, but once you get the hang of it, you can get a guesstimate of it, and it's not too bad, really. As long as you are under 10, you're fine. At about a pressure of 10 millimeters of mercury, you start to develop collaterals. And up to this point, it's fine. You can have collaterals and things are okay. The problems arise when you start to hit or cross the double figure marks. The higher the number goes beyond 10 of HPVG, the higher the incidence of bleeds. So if at a HPVG of about 15, you have a very high risk of bleeding. If it goes between 15 and 20, you start to get ascites, and more than 20, you definitely start getting encephalopathic. The other reason, so historical teaching of portal hypertension was that it happens because of fibrosis and increased flow. There is structural resistance, but increasingly the role of stellate cells and myofibroblasts, as I was mentioning earlier on, is being increasingly recognized. Because what happens is, when this happens, more and more hepatic stellate cells get recruited into the system, and these are contractile cells, and have some pulsatile nature in them. So as more and more of these get recruited, they tend to squeeze the portal system more, and hence increasing the blood pressure, the portal pressure with increasing time. And more the stellate cells get recruited, the higher your portal pressure, and the contribution as these HSC cells are being recognized increasingly in time. This can be controlled. Simvastatin in decompensated cirrhosis, mostly the child poo class B, in preclinical study has shown some remarkably positive results. It does not reduce rebleeding, but is being shown to increase survival in patient in cirrhosis, but it is not widely employed in clinical practice just yet. And how it works is difficult to say, but I won't go into detail. It's a bit too complex. It's to do with the Rho A and Rho B kinase systems, but we'll skip that for now. How is the other landscape changing? So that was the traditional teaching that acute liver failure is a hemodynamic disease. It really isn't. Increasing role of systemic inflammation is being recognized, and we'll come to each of these in a minute. Albumin dynamics. Albumin is not just about oncotic pressure. There's more to albumin than just the oncotic and colloidal osmotic pressure. The mitochondrial dysfunction, we'll talk about it, and the OXPHOS, or the oxidative phosphorylation stresses and dysregulation, which is increasingly be recognized in addition to the metabolic diseases that happens in them. So what happens with systemic inflammation? Now, 90%, or it says 99 on my slide, but close to 100% acute decompensation of acute liver failures will have signs of systemic inflammation. Now, does that mean they are infected? It's very hard to say. It's a bit like pancreatitis. You know, you get a patient of pancreatitis, you'll have a mega CRP and a mega white count. Does that mean they're infected? That's why the guidelines say do not start antibiotics. In contrast to that, here, you will have a very, very low threshold to start antibiotics. And actually, antibiotics in acute liver failure correlate with survival, and we'll talk about it a bit later again. There is a directly proportional correlation to mortality with the level of interleukins, and all sorts of interleukins rise. Of particular interest is IL-6 and IL-10. IL-6 is particularly risen in acute liver failure and is of paramount importance. Don't get flustered with these abbreviations, the PAMS and the DAMS. PAMS is nothing but pathogen-associated molecular proteins, and you might have read it if you're reading about sepsis and pathophysiology of sepsis in general. So PAMS is nothing but what happens is when you get an infection or bacterial translocation in these patients, the bacteria breach the wall of the gut, really, and they start to release lipopolysaccharides and flagellin kind of materials. and they then amplify and recruit interleukins and cytokines, which manifest as sepsis. So this is essentially the PAMs are coming from outside. In contrast, you have DAMs, which is damage-associated molecular proteins. These come from in vivo. These comes from dying and damaging necrotic hepatocytes. So one is coming from outside and one is coming from inside. They all mate with the common aim of amplifying the systemic inflammation. And this seems to be playing a major role in the generation of acute liver failure. The diagram looks complex, but essentially summarizes what I have just talked until now. Let's talk about albumin. The traditional talk about albumin is low colloidal osmotic pressure. The fluid moves this, the hydrostatic pressure causes this, and the Starling law causes this. Hence, top up the albumin, they will get better. I wish it was that simple. Albumin is not just a fluid. It is a protein binder. It transports stuff. It detoxifies stuff. Natural albumin is pretty strong antioxidant, and it does have some effect on immunomodulation. What happens in patients with cirrhosis and under the effects of the PAMs and the DAMs that we've just discussed is the cysteine residue, the cysteine terminal of the albumin molecule goes some radical changes. And as a consequence, the conformation of that albumin changes. So rather than being a detoxifier and a kind of anti-inflammatory agent, it starts to sway on the pro-inflammatory sides. And that is why the albumin, which should be beneficial and protective, starts to become a cause of concern. Now, you give these patients albumin from outside, does it achieve the same effect? The answer is not to the same degree, but certainly to some extent, it provides both quantitative and qualitative. With albumin, it's like anything in intensive care. There are believers and non-believers. I was brought up in a system and I trained in the system where we believed in albumin, so I still vouch for it. Right. This is a schematic diagram of the effects of circulatory dysfunction and compensatory mechanisms and the role of albumin and natural vasodilators which exist in the system for these patients. Talking about mitochondrial dysfunction. So what happens is, if you think about it, this is standard biochemistry. So loss of OXPHOS or oxidative phosphorylation, what happens is, as a consequence of that, you generate reactive oxygen superoxides, really, or reactive oxygen species, and particularly the peroxides. They are spectacularly damaging to an already weak liver. Not to mention that, as you know, that aerobic metabolism will generate 36 ATP per molecule of glucose, whereas you take the glucose away and your generation of ATP becomes one anaerobic, so creates a further acidotic environment. Two, makes the system supremely inefficient. What about the metabolic changes? So what happens is that your aerobic metabolism is glucose dependent for its efficiency and generation of ATPs. And with increasing time, as the liver starts to fail, hypoglycemia, as you know, is a bad sign in liver failure. That means you are reaching an end of the game here, and there's not much you can offer short of transplant. It does come late if they are managed early properly, and it is the cells that get starved of the glucose and the anaerobic metabolism predominates. What then happens is, and any catabolic affair is supremely destructive, and liver is no different. Physiology books will say that you can actually lose 80% of your liver and still live a reasonably normal life. And that is still correct. You only need about a quarter of your liver to live a normal life. But when you get starvation deprived, you start to eat on your proteins as a source of energy. And hence you see extreme sarcopenia in muscle fibers under a microscope. And hence you see those tiny, thin, muscle-wasted individuals when they're present. There becomes a imbalance between the saturated and the unsaturated fatty acids, and that what happens is that has a significant impact on detoxifying the toxins which are circulating. As a consequence of all this, you have an ammonia overload. Ammonia is an osmotic diuretic, as you know, but it is also for false neurotransmitter. Now, as long as you have substantial stores of glutathione synthetase, you will manage that ammonia reasonably well. But these resources get exhausted, and you don't have enough glutathione synthetase. So what happens is whatever ammonia you break down in the brain, you break it down into glutamine. And that in turn is directly responsible for causing your brain swelling and edema. PREDICT is one of the studies I would definitely recommend to read. It is a fascinating study, and it did take them a while to publish, partly because of COVID as well, the authors tell me. But essentially what they are saying is, if you look at compensated cirrhosis, they seem to live. They seem to live for a reasonable length of time. If you look at the 1-year mortality at the bottom figure, the acute mortality in compensated stable disease is practically none if they don't come to hospital. It is during the course of the year their mortality remains high. Compare that to the acute presentation of fulminant or acute liver failure first presentation in hospital. You see the difference here is that your mortality, which is the blue graph, which shows death here, remains exceptionally high. And the reason for that is that our basic standard intensive care or hospital treatment for these patients are severely wanting, severely deficient. And that's why these patients die. And we'll come to, towards end of my talk, we'll come to the mistakes that are commonly made in managing these patients. I am wary of the time, so I'll keep an eye on the time as well. That's why I keep on looking at the watch. So I got about 5 minutes. So where is the future? Now, traditionally, we're not talking about variceal bleeds or banding varices. Hence, we have not talked about use of terlipressin and stuff like that. But serlaxin is a derivative of the same class, to put it very simply, but without the overall side effects of vasopressin. Those of you who are old enough, like myself, to have done intensive care for some time will realize that pentoxifylline makes its appearance every about 10-15 years for one reason or the other. Some recommendation or thoughts come about, how about pentoxifylline? All it is trying to do is to work as a microcirculatory vasodilator and increase the flows. Okay. Until we have these in clinical practice, we are fairly limited with what we can do. You obviously do the basic treatments where we go wrong: volume, oxygen, antibiotic, standard of intensive care. But until then, albumin and terli are the only definitive treatment which can make changes to the outcome. Yes, there are other garnishing or finesse drugs that you can use, and we can talk about it in the discussion when we get there. So what are the common mistakes we tend to make? And the more I talk on this around the place, the more I get convinced, the more I go to different places to give second opinions and stuff like that, the more I see it. PPI, so proton pumps inhibitors, grossly misused drug in this pathology. There is this school of thought that, oh my God, they have had a variceal bleed, give them a megadose PPI for rest of their life, otherwise they'll rebleed to death. That is, excuse my French, but that is nonsense. It does not work like that. The untoward effects of using unregulated PPIs are massive. What it does is, there is data coming out now, it increases the incidence of spontaneous bacterial peritonitis, unsupervised used. There is incidence that the frequency of decompensation is increased in unsolicited use of PPIs. And last but not the least, even if there are very specific indications of using long-term PPIs, and the most common being a gastric ulcer. Even for a duodenal ulcer or phagitis or Helicobacter, you don't need a lifelong treatment. And even if you do not need high dose. So that's about PPI. What about beta blockers? Propranolol has stood the test of time over the years, and it still is a very good drug when used appropriately. The two caveats to that is the when to use, or when not to use propranolol. Obviously, common physiology would dictate not to use it in vasodilated states when your cardiac output is already low. But more important thing is, you do not need a high dose propranolol. 40 milligram propranolol is good enough orally for these patients. And what is coming off late again is carvedilol seems to be more specific for these patients in certain conditions of acute liver failure. So when would you use propranolol would be the cases where the ascites is refractory, when the varices are less than 1, then you have a case of using propranolol. However, if you have more than 2 varices, ascites is manageable by diuretics, then the data show survival is better with carvedilol. You start low and you generally build it up. Paracentesis, this is where we get it wrong. If you get a patient with acute liver failure, look for ascites, and if there is ascites, tap it. You may not drain it, tap it, because that changes the outcome. You pick up the SBP and you do the right antibiotics or antimicrobials. Where people get it wrong is this worry, oh my God, they are coagulopathic. But even in the most basic units, we live in the era of ultrasounds. And I find in India, you guys are absolute experts in ultrasound. I think Deepak sleeps with an ultrasound at times. So yes, tap it if you can, and it will change the outcome. Antibiotics, there is now unequivocal data to suggest that nosocomial infection, if a liver failure patient gets infection in the hospital, he's more likely to die. And that's not a surprise, because a hospital infection is more likely to be a MDR, multi-drug resistance, as compared to a community infection, which is unlikely to be. Start early, start brisk, start broad spectrum, and then narrow it down once you have the result. The most difficult pathology to treat in intensive care by far in my book is hyponatremia. Hyponatremic patients carries high mortality in acute liver failure. And in general in ICU, hyponatremic patients don't do very well. Now, depending upon the stage they can present as hypervolemic hyponatremia or hypovolemic hyponatremia. And sometimes you have to restrict fluid to we restrict to 1 liter a day. And it takes time and is frustratingly slow, but that is the only treatment. Comorbidities, and I'll particularly mention about one comorbidity, which is type 2 diabetes. There's a direct correlation of hepatic encephalopathy now with poor glycemic control. So comorbidities do definitely make a difference. Renal failure, CKD on the background of alcoholic disease is bad news. Pulmonary hypertension in presence of alcoholic liver disease is bad news, as an example. These patients are inherently malnourished. They try to make up for their calories by volume and what you would call as empty calories. You need to feed them early. and you feed them more frequently, their appetite is not great. We tend to give them 6 meals a day rather than 3 meals. And even if it is small portions, sometimes you will reach a situation where NG feed is not tolerated in them, and have a low threshold to give them TPN if needed. And last but not the least, there is this myth that, oh my God, the coagulation is grossly deranged and they are all coagulopathic. By and large, a liver failure is a procoagulant disease, although your numbers don't reflect it. Unless you do a proper TAG or ROTEM, you will realize, yes, your APTT, your platelets, your INR is all over the place, but bar esophageal variceal bleeding, these patients do not bleed. If you talk to our chair panel member, Dr. Govil, he will tell you that they never reverse the coagulation in liver failure patients where they do trachees. And this was a learning point I learned from him many years ago. You do not need to give them platelets to put in a central line or do a paracentesis. Just use low molecular weight heparin. They are portal vein thrombosis is more resistant to treatment. You can treat bleeding, but once you get PVT, your survival does get severely affected. I'm a couple of minutes over, I think, and I will finish my talk with this summary slide, which essentially shows you the changing paradigm of liver diseases. And this summarizes what I've spoken in the last 3/4 of an hour. Thank you, guys.
Oh, that's wonderful insight, sir. I mean, really delighted to know a lot of new concepts that you have come up with the discussion on decompensated hepatic failure. It is very difficult to differentiate acute kidney injury, whether it is related to liver or the other factors. Hepatorenal syndrome is one of the entity which is really difficult to treat and to classify is also a little difficult. I know the guidelines have come up and there are different recommendations to diagnose hepatorenal syndrome. How do you treat hepatorenal syndrome and when will you be able to diagnose it appropriately? I would like to have your views on this. And there is a question also pertaining to this entity like hepatorenal syndrome. Over to you, sir.
Okay.
Ravi Kumar, sir. Yeah.
Does anybody in the panel want to answer this, or do you want me to answer?
We have Dr. Deepak Govil also, sir, and Dr. Akila, if you can also would like to highlight on this.
I would like to hear Dr. Ravi's view first.
So I did a talk about HRS in the recently concluded ISCCM meeting in Ahmedabad. If you see, HRS was an unnecessarily complicated entity that was historically there. We used to call it HRS1 and HRS2. With the new guidelines, that definition has now changed. We now call it HRS-AKI, which is essentially HRS1, and HRS-NAKI, or some people call it NAKI, which is subdivided into HRS-CKD and HRS non-AKI, essentially. And the difference is, what has changed is, earlier you needed a 3-month creatinine for somebody to be diagnosed as exclusively being HRS1 or HRS2 or whatever. That definition is now taken away. Now, what you now need is the baseline creatinine present on presentation. That is what you need, okay? So somebody presents with acute liver failure, day 0, you do a full set of bloods, you get a creatinine, okay? And from that creatinine, you start working on, if as per your lab reference, that creatinine is more than, I can't remember the exact figure on top of my head, but I think it is, in our units, it is more than 3 times. If I remember, I'll stand corrected on that. In addition to liver failure, then then okay, you can diagnose. The caveat is the same though. You have to exclude sepsis, okay? Where the establishing diagnosis of HRS becomes increasingly difficult is the fact that number one is that you have to give them 2 days of diuretics to see if the difference is being made in the urine output and your creatinine numbers. And last but not the least, what you also have to see is they have to be given 48 hours of albumin. So it is still a complicated diagnosis. With regards to your question about how do you manage them, the management short of dialysis remains exactly the same. You treat as if you're treating the liver function and maintain a mean arterial pressure. This is what we do. I don't know what others think really.
Yeah, sir. So before going to sir, this question, basically, I would like to highlight some of the important interventions in a bridge to transplant in the liver failure patients. Particularly, I would request Dr. Deepak Govil sir, because sir is means very expertise in doing a lot of this therapies like plasmapheresis, like CRRT. So in which situations these things can be initiated, sir? If you can guide for our fellows and our students, it will be a great help, sir. And there is a question also from one of our students, sir, from that respect. Plasmapheresis, CRRT, Mars, and albumin dialysis.
I can see this question, the role of Mars, Prometheus, albumin exchange in ALF and plasmapheresis. So there are two distinct things. One is when we are planning to do transplant and we want to bridge, like in Western world, it is sometimes becomes difficult to get a donor. But in Indian context, when we are having a live donor, a related live donor, sometimes we can plan the liver transplant easily. Sometimes when there is no donor, then it is not plannable. So there are two distinct situations as far as in my clinical practice. One, patient is ALF is there, family is getting, somebody from family is getting worked up for donation, and then we have to bridge that 1 2 hour time. And another possibility is where we know that in North India, I'm sure that Dr. Akila's place, they are having much more cadaveric transplants, but in our place we hardly had any cadaveric transplants. So we day 2 day 1 we know on the ALF that this patient don't have got any live related donor who can be a potential donor. So then we know that either whatever we do, whether you call it a bridge or it call a desperate. So in this situation where there is no possibility of getting any donation or new liver, then of course we go for plasmapheresis, no doubt about it. So if bilirubin is high, patient is ammonia is high, having sign of encephalopathy, brain edema, then we go for plasmapheresis, no doubt about it. But in that situation where we know that in a day or two, some family relative is getting worked up for potential donor, and patient might get a donor, then sometime we try to wait for little time, maybe 24 hours or so for plasmapheresis. But if creatinine is high, if ammonia is high, CRRT we start straight away.
Sir, any cutoff for ammonia means in such kind of patient?
It is not the cutoff ammonia. It depends on, I'm sorry, I used the wrong word. It is not the ammonia. Mainly it is the cerebral edema or the sign of encephalopathy. Dr. Akila, can you highlight your practice?
Thanks, Dr. Govil. When we consider as a bridge to liver transplant, there are several modalities which have been researched everywhere. And as you rightly said, the only evidence base so far is plasmapheresis. So any patient who comes to us with the fulfilling criteria, we subject them to plasmapheresis. At least 3 sessions we give them. Because it's very difficult to predict which patient will recover or will require a transplant. So it's better to support them from the early stage. And CRRT is initiated when there is sustained hyperammonemia more than 150. That predicts the onset of cerebral edema. So when it's persistently more than 150 micromoles per liter, we start off the CRRT. That's what we do. But one thing which is different, I think it's not very common in the North India, is the yellow phosphorus poisoning that is very common in South India. So these are patients who have severe form of acute liver injury, but they do not have acute liver failure. We do not have great guidelines as to how to manage them, but LTSA has come up with the consensus guidelines. So they recommend using plasmapheresis in these patients, even without acute liver failure, without encephalopathy. With ALI as well, we can start using them. So these are the indications of plasmapheresis in our unit. Other extracorporeal support devices, that there was a question that I saw in the chat window about Mars and Prometheus. We do not have any experience, because in all the reviews which have been performed so far, they have not shown any survival benefit in patients with acute liver failure. But there was one interesting finding which has come up recently, I think in February. US ALF study group, they have looked into their patients over the last 21 years, and they have said that Mars does improve survival in patients listed for liver transplant. That's a relatively new finding, which is evidence-based. But having said that, it's not a prospective study or a randomized study, retrospective database study, but none others have shown survival benefit.
And what about the cytoserve in case of this acute liver failure? How frequently you use, Dr. Akila?
We've never had to use it, actually. We've never used it. There are a few case reports suggesting it might work, but again, no robust evidence to justify use.
So I've just replied to that question, really. I completely agree with Dr. Akila. With regards to Mars, there's a machine sitting on the side. We hardly ever use it. I think it is very important to understand that Mars is not like a dialysis machine. Mars is only if you're going to transplant. That's only when you use Mars. Please correct me if I'm wrong. That is number one. With regards to cytosorb, we don't use it. We don't believe in it. And our reasoning is, by the time these patients actually present to you in intensive care, the whole idea or physiology of using or the whole idea of using the cytosorb is gone, because the cytokines have done what they need to do. So it's pointless to use cytosorb. We don't use it, and we have never used it. We did try it when it was first brought in. Last but not the least was a question about Lola. Austrians use it a lot. I have seen it used. I'm not entirely sure about the benefit, because we believe that similar results can be achieved by simpler things. That is our take on Mars, by the way.
There has been increased use of N-acetylcysteine. I mean, every physician or intensivist must have really prescribed N-acetylcysteine for all patients with the liver failure. What is your take on Professor Ravi Kumar and all the panelists? I mean, whether it should be used, which is the ideal indication for use of N-acetylcysteine? I know paracetamol toxicity, there is definitive indication, but in liver failure per se, especially with sky high liver enzymes, what is the role of N-acetylcysteine? Can you just highlight on that?
I can tell you about our practice. We will give NAC to everybody, full stop. You know, irrespective if the liver functions are massively deranged, irrespective of the pathology, we will give NAC to everybody for two reasons. One, it is a very benign drug. It only has minor side effects, a bit of vasodilatation if given too quickly. And two, resource constraint wise, it is not a supremely expensive drugs. And I would be quite interested in what others think as well, actually.
Yeah, what is your take on Dr. Divya about the N-acetylcysteine?
N-acetylcysteine, definitely the role in paracetamol poisoning is well known. But in studies, it has shown that even in liver failure with indeterminate causes, other causes also, it has found to be of benefit. So we are using N-acetylcysteine for all patients, like Sir has said. In the prescribed doses, we have been using for all patients.
Wow. Govind sir and Dr. Akila, what is your view on this?
Yeah, there is a question for the dose of the NAC, Dr. Akila. So there are various doses. So what is the ideal dose? Means in what dose you use?
First of all, going by the use of NAC, whether it's indicated or not, is paracetamol poisoning. There is no doubt about it. But this has been an age-old practice. I agree with Dr. Ravi Kumar. We use it on all patients with acute liver failure. As he said, it's a benign drug and been in use for a long time. We are worried about stopping it. Maybe it acts by improving the sodium, as people from King's believe it. It can improve the sodium and it can work in acute liver failure that way, in an indirect way. I'm not sure how much of it is contributory there. Yes, we would definitely use in all forms of ALI or ALF.
And how long do you all use it?
This has been proven that any use beyond 5 days is of no effect, even with paracetamol poisoning. Paracetamol poisoning, I think the most of the recommendations are for 72 hours, but this has been proven that beyond 5 days, there's no use of it.
Yeah. Sir, another question from Bina is from the ammonia level is means want to ask. So arterial ammonia or venous ammonia, what do we check actually, and what is the significance of different ammonia level in different blood gases? So Govil sir.
Look, ammonia level, as Dr. Akila has said, 150 correlates with cerebral edema, but what I have seen in my clinical practice, it's very difficult to say which is the cutoff. So it is much better to rather rely on ammonia level to look for the cerebral edema, where it is and how fast it is developing. And on the bedside, we can use the ultrasound to identify the potential patients, and then we can plan for CT scan. Incidentally, at our institute, we are having a portable scanner, so that is not a big challenge to get a repeated CT scan done, except the radiation risk and the cost. But again, ultrasound helps in identifying. As far as the ammonia venous and arterial, again, it's a debatable. Many places, everybody practices the arterial ammonia, but in a ALF, if patient is not having A line, then repeated puncture becomes a very difficult and challenging task many times. But of course, majority of these patients, we put arterial line just to avoid all these things. Repeated ABGs are also needed. So most of the time, we rely on the arterial ammonia. Dr. Ravi or Dr. Akila, if you want to add anything, please.
Now, of all the lab parameters that we've seen so far, ammonia is the one which is prone to have a lot of false values. Actually, it depends on how you sample them and how quickly you store them and process them. It has to be transported in ice cold way, actually. So there'll be a lot of problems in the way they measure. It has to be in a standardized way. I think if it comes from a liver unit which does it all the time, then you can rely on the values. Coming from outside, you do not give much importance to one value alone. You'll have to see how is it measured. So that is something which a word of caution to all the postgraduates here. And arterial is always better, as Dr. Govil said. We go by arterial ammonia.
So another question is regarding the cerebral edema. So the question, if Dr. Divya, if you can highlight, what is your protocol regarding the cerebral edema management for ALA patient?
Cerebral edema, we don't use any invasive monitoring for that. We go by clinical parameters, or we do transcranial Doppler. We've also been using optic nerve sheet diameter to look for changes every day in our ventilator patients. As far as management is concerned, it is to give absolute sedation, bed rest, ventilate the patients if they are encephalopathic, avoid any stressors which might increase the ICP. We also use hypertonic saline and maintain a target a sodium of 145 to 155 in all these patients.
So what will be the ideal osmotic therapy here? 3% saline versus mannitol. I know it may be a stupid question. So many studies have already shown that 3% saline may be equivalent to mannitol, and mannitol may be harmful, may cause acute kidney injury. But I really want to know from all the panelists and Professor Ravi Kumar also, I mean, in a real-time situation, if you have to use it, which one would you choose? 3% saline versus mannitol? Professor Ravi Kumar, from you, I mean, we can start from you. Your honest opinion on this, actually.
My honest opinion is actually we don't see that much of cerebral edema, I have to say. especially in alcoholics, we don't. Maybe your demographics are different. If you consider acute decompensation in chronic liver disease or liver failure, by and large, their brains are quite atrophic anyway. So you have plenty of space in the skull anyway. So you're unlikely to have a tight brain. That is number one. With acute cerebral edema in acute fulminant hepatic failure, they die, full stop. There's not much you can do if they are presenting complaint. So in our practice, I cannot last time remember, I must have used it at some point. I cannot routinely remember using any osmotic therapy because we do not get tight brains. We do TCDs. It is more of a postgraduate training exercise rather than clinical practice on a day-to-day basis.
And on the same context, I would like to ask Dr. Akila, what are the recent guidelines regarding the cerebral edema management in ALF from one of the trainee to all the panelists? The question is being asked.
I don't think any recent guidelines have come. I think our understanding has just stayed there, and we are very well off with the understanding of ALF, whereas ACLF is a problem. The guidelines are to protect the brain, and I think we have understood well. That's why the incidence of cerebral edema has come down. Protecting the brain is the main thing. That's why preemptively starting them on CRRT, following the ammonia levels, do not wait for them to go down. Ventilate them early, and there has to be aggressive monitors, neurological monitoring, and anybody who has acute liver injury, when they start off with a liver injury, you can use simple tests like the number connection test to monitor when they're going in for use of a transcranial Doppler. So all of those things. And regarding hypertonic therapy, use of I think UK, they have 30% hypertonic saline. There's a big difference in the doses that we use. 3% might not be good enough if you use the same dosage, and you're going to use a very big dose when you have to get 3% saline. So I agree, we have not had to use any boluses of these drugs in any of the patients. But the indication is when they have an acute crisis, when you feel there is an ICP surge, which is evident on your monitor, or there's pupillary dilatation, that is when you use the bolus of this mannitol or a hypertonic saline. Otherwise, we don't see the need for it as a routine measure.
And you routinely monitor, madam, transcranial Doppler or optic nerve cell diameter?
We do both. ONSD might be not a good thing when they are spontaneously breathing. Once they go on to control ventilation, it's because ALF is very rare, not very commonly seen. So just to keep our hands on skills, we use both ONSD and TCD, and it's easily available at the bedside. So that's something we do.
Which method of ICP monitoring will be ideal here in this situation? I know clinical monitoring is very, very important. And apart from transcranial Doppler, I think frequent pupillary check also would be very important.
Yes.
Any other method by which we can monitor
pupillary
ICP?
checks and frequent ammonia checks will go a long way. If your ammonia persistently stays high, despite putting them on high volume CRRT, again, it's a bad indicator.
How would you, how soon would you intubate? Whether you would like to wait, or the encephalopathy to worsen, or you would intubate the patient, put him on ventilator on grade 1, grade 2, grade 3, or grade
At grade 2, I think you should. At grade 2 encephalopathy, we start intubate them.
So preemptive intubation and ventilation will definitely help us to
Grade
prevent.
2, I wouldn't call preemptive. I think it's definitely indicated when they reach grade 2 in fulminants at least.
You see, I have my views on this, if I can.
Yeah, please go ahead, sir.
I believe that we lose more patients from aspiration pneumonia secondary to acute liver failure than actual grade 3 or 4 encephalopathy. And hence we change our practice going back about 7-8 years ago. We intubate early, and we intubate really early. We will not wait. We will intubate really, really early. And our reasoning is they aspirate at the drop of a hat, really. So we will go in very early, because the other thing is, if you intubate them early, then you can manage them better. It is better for nursing staff, because these patients are thrashing, they are withdrawing, they are dehydrated, they are sweaty, and intubation just gives you more control to put in lines, do invasive procedures and XYZ. That's why we tube really early.
And which sedative agent would you use? I mean, propofol is quite commonly used in majority of the centers, and Dr. Govil has already answered the question. What is the role of dexmedetomidine in these patients? Why you want to sedate these patients? Any take on this? I mean,
there's no point
dexmedetomidine.
using it. There's no point using it acutely. There's absolutely no role of using it acutely. Once you've done what you need to do and things are moving in the right direction and you are struggling to wean and with sedation, then yes. Why use something which is so expensive and complicated, really? You know,
Yeah.
We do use dexmedetomidine sometime in initial phase when the patient is in grade 2 and he is too restless, or in withdrawal when he's like fighting and thrashing everybody and want to pull out everything. Most of the time at that juncture, everybody decides to intubate. But sometime if you are not intubating a short time period, that time this dex can be used. That is what we are doing.
Yeah.
Say that
dexmedetomidine has been found to be very useful.
We are using. Dr. Shrikant Sahaspude wanted to ask something.
Yeah, very interesting question actually, sir. What is the ideal
Dr.
time for
Shrikant.
liver transplant in yellow phosphorus? Is there any evidence of preemptive liver transplant in yellow phosphorus considering the high
As
mortality?
early as possible, I would say. I mean, I would like to hear from the others also.
It's one of the, I think, challenging topic, part to manage.
Now, what we have seen with yellow phosphorus patients are the moment they become encephalopathic, they go down rapidly. So we thought we have to transplant them the moment they become encephalopathic, because they have a ALI for a long period, and most of them recover, at least 95% would recover without a transplant. But those who develop encephalopathy ultimately need a transplant or they die, has been our initial observation. But over the last 2-3 years, what we've seen is if we intubate them and then continue supporting them, we've had a lot of patients who've recovered after that stage also. And another interesting finding in these patients is toxin accumulates in the body, and after the new liver goes in also, it redistributes and causes the same amount of cholestatic injury to the graft. So we've had struggle with 2 of our patients where we had to plasmapherese them for a long period. We'd lost a patient also. So that changed our thing, that we don't have to aggressively transplant them immediately after they become encephalopathic and they get intubated. So we do give them some time, extended period of, they don't get better with 3 episodes of 3 sessions of plasmapheresis. They take a longer time. Once the encephalopathy gets better, that is when we think about weaning. So I do not agree that they should be transplanted as early as possible. It does not give good results as you think, because the cholestasis continues, and the biopsies have shown that they have significant amount of fat in the liver as compared to the previous pre-transplant biopsy. It's the same.
Plasmapheresis, preemptive or early plasmapheresis would definitely help them.
Again, we do not know, because
we don't have, these are all anecdotal data that we have.
So I mean, the LTSA consensus, I mean, we were part of it, we initiated it. We do recommend plasmapheresis, but that's not the gold standard of therapy. We do not know it works, but we've been giving it because the problem usually happens 4 days after ingestion. We do not know if that patient who's ingested and come to us will manifest with liver injury also. So by doing a plasmapheresis even before liver injury happens, that is what many of the centers are doing. I do not think that is warranted, because looking at the data from government hospitals, even if they've ingested a fatal dose, which we think is a fatal dose, 4 days later, they do not manifest signs of liver injury. So we should not be aggressively plasmapheresing them at least signs of liver injury. So we have a cutoff of 250 of transaminases. That is when we start doing plasmapheresis on them.
This is a bit tricky actually. If you keep on waiting, they will deteriorate rapidly and you're left with nothing actually.
When they are in a center where you can do everything.
And madam, the same thing from Dr. Shrikant Sahaspude. So what is the physiological basis of plasmapheresis in these non-immunological patients of yellow phosphorus? Any of the panelists, if Govil sir or Ravi sir also can want to talk on this.
I have no idea. I've never seen one. I don't even know what it is.
I am also not having that much experience in yellow phosphorus patients. I have seen only very few in my clinical practice here.
Madam, what is your take?
Again, we do not know what it does because it's a protoplasmic poison. We're not removing toxins. We're definitely not removing the toxin by doing plasmapheresis. We think it might work on the SARS part.
Yeah.
SARS part and the supporting liver.
Supporting liver,
A little bit the byproduct of the liver failure, they are being removed. Definitely the ammonia is being removed, the other toxins likely to be removed. So maybe that way it may be helping.
Sir, on the same contest, one of the delegates has asked, like, if you do this extracorporeal therapies, so does it confound the patient for the liver transplantation? Because sometimes sometimes the transplantation get delayed because the patient is improving or some kind of things. Is it a confounder, all the extracorporeal therapies?
But I think we definitely get some time to really think whether that patient will require transplant or not. It gives us
all
some
these
time
extra,
to really
as Dr. Akila has already said, all these extracorporeal therapy, the evidence is still only with the plasmapheresis, and little bit evidence and much more established practice is Mars after plasmapheresis. I would say there are few centers in Europe who are like die hard for Mars and is still continuing, but others, they have got very less, like it's just a case series presentation. So if you are desperate, nothing to do, if you want to do something, if somebody is trying, it is difficult to comment upon.
And sir, what about the infection risk? Because some centers, they prefer to do CRRT instead of doing the plasmapheresis because they feel that it increases the chances of infection.
Look, the chances of infection is there in every extracorporeal circuit, whether it is a CRRT or plasmapheresis or Torre or cytosorb. Wherever we are taking out blood and sending it back, there are multiple connections, there are multiple joints, there are multiple points where it can get contaminated. So starting from the putting a line and connecting the circuit and priming the circuit, anywhere it can get contaminated by the hands of the performer, the person who is performing the procedure. So again, the risk is always there. If I compare, I'm sure Dr. Ravi and Dr. Akila can comment on this also. If I compare plasmapheresis vis-a-vis CRRT, I would say in my mind, the risk of infection is same, except in plasmapheresis, we have to replenish the antibiotics because those antibiotics which are protein bound, they will go down the drain. So we have to load those antibiotics again. If we don't do that, then the circulating blood level, the blood turf level of those antibiotics will go down, and then they will not be effective. That is my take on it. So that is the only difference between CRRT and plasmapheresis, which I can see. Even in the CRRT, we have to increase the dose of few antibiotics, which are water soluble and going down the drain. So if we are not doing those changes and sepsis is breached, asepsis is breached somewhere, then you had it. Dr. Ravi and Dr. Akila can also highlight their experiences.
Now, when it comes to plasmapheresis, it's more of a non-selective removal, isn't it? It removes all complements and immunoglobulins. With CRRT, we've understood the dose modifications which are required with antibiotics. That is not understood with plasmapheresis, how much needs to be replaced. So I think there is a difference there. And we did see high incidence of sepsis in patients who've had plasmapheresis. We used to do them for early allograft dysfunction, post-transplant, post-LDLT. But we did see a higher incidence of septic complications in those patients. We do not know, we can't attribute it to the procedure alone. These are patients who've been cholestatic, IML, been sick for post-op. I mean, that could have contributed, but that's something we've seen. Going by theory, I think plasmapheresis might have a higher risk of infectious complications because they seem to be removing all the protective factors, immunity factors as well. So it's all theory. I mean, there's nothing comparing them without for the incidence of sepsis. Dr. Ravi Kumar,
we have seen absolutely no difference in infection. What you must realize is the pathology. You have got a pathology where a patient is at a 4 to 6 times higher risk than a normal individual septic patient to get a severe infection. So the pathology is there. You're a sitting duck. It does not matter what cannula where you put. They are a higher risk. I cannot vouch and say one is more infective than other. I do not think that there is a difference at all, really.
So there is one question: which type of plex is recommended? I think centrifugal plasmapheresis is more beneficial. What is your take on this entity, Dr. Akila and Dr. Govil sir? I mean, what do you think? I think all of you all, I mean, must be doing centrifugal plasmapheresis
No,
only.
we are not doing centrifugal plasmapheresis. Earlier, we were doing centrifugal plasmapheresis, but we have shifted to the pump-based plasmapheresis, and we are using the CRRT machine for plasmapheresis. There were 2-3 reasons that blood bank people were not interested in doing the high-volume plasmapheresis with extended time. We do close to 30 to 40 bags of plasma and take it to 6 to 8 hours of plasmapheresis, which they hardly do because they are time-bound people. And then many times they want to put saline or albumin in place of plasma, which we don't do. And then they want to put some steroids, some Avil, some other fancy drugs just to avoid any reaction, which we hardly do. So in last 4 or 5 years, we have completely taken over the plasmapheresis from this blood bank people, and we don't have got centrifugal pump except in blood bank. So we are using our own CRRT machine.
Okay,
I don't know
30
whether it's
to 40,
right practice or wrong practice.
30 to
but
40
is,
bags of plasma is still, I mean, I think it's still very high volume plasmapheresis, I guess. I mean, with plasmapheresis, I mean, 6 to 8 bags of plasma should be sufficient, and we can.
no, it's not sufficient. If you go to the literature, the evidence which is coming up is a high volume plasmapheresis. So 6 to 8 is, I would say, it's a daal mein chhauk lag raha hai bas. Nothing much.
Yeah.
I may be wrong. I'm not saying that what is right or wrong. I can just tell you my practice and my experience. Hard evidence is not there for anything, so it is just a guesswork. Dr. Akila and Dr. Ravi also, please
Dr.
share your
Akila,
experience.
yeah, we can.
We're still
Okay,
using the centrifugal pumps. We have support from the blood bank all the time. We've not experimented with the one on the CRRT machine. And yes, we also do a high volume plasmapheresis in these patients.
Professor Ravi Kumar sir.
We use ultrafiltration.
CRRT.
Yeah, we use our own machines. Our dynamics are different. We are a public healthcare system, you see. So our dynamics are very different. We are nationally poor, but not individually poor when it comes to healthcare.
Sir, very interesting question. If Dr. Divya also can answer, what is the cutoff of INR and before doing any procedures? And do you routinely transfuse FFPs and other blood products?
As I said to you in my talk, no.
Yeah.
The answer is
No cutoff.
absolutely no. Because this is something I'm quite passionate about. What you must realize is if you give somebody platelets, what are you trying to achieve? Are you trying to increase the numbers? Because in vitro platelet is not a qualitative platelet. Okay, you can increase the numbers, but you cannot guarantee that you have improved the coagulation. That is number one. Gone are the days when we were doing lines blindly. Okay, we now do lines under direct vision in real time. I do not see a point of reversing coagulation. I mean, the expert is sitting in your panel, ask him how many trachees he's done without reversing coagulation in liver failure patients. Yeah? We never do. The only time we will give them some factors is if the platelets go below 20. Okay, because there is some weak evidence that the incidence of intracellular bleeds goes really high up below 20. It's not a robust evidence.
And what about INR, sir? What cutoff value of INR basically? Suppose the INR is 5, 6. Still you put a line without giving any FFP or do you do a TEG?
We do early tags in these patients. So we hardly, yes, we see INR and this and that. We hardly rely on them, to be honest. Why would you rely on INR in a liver failure patient when you have a TAG?
Absolutely.
TEG is not available in all the centers except some corporate hospitals. It's not available in majority of the hospitals, probably. They're getting guided by INR values. Yeah.
I get that completely, but all I'm saying is clotting factors for invasive procedure in liver patients all it does, it gives you a false sense of security. It does not reduce bleeding, is my view, but I'll stand corrected.
They are always they are in a procoagulant state, as you already said, like in, so the INR values may not have any implications pertaining to insertion of lungs. See, some of the patients are on midodrine. What is your take on midodrine? I mean, would you prescribe or would you differ from writing midodrine to your patients? I mean, I still have a query about this. I'm curious to know what is the role of midodrine in patients with the liver failure.
Sir, Govind sir.
Yeah.
So midodrine per se for liver failure, midodrine works in whatever we do. It works in HRS if we are shifting patient out of ICU and in the room or going home. So in place of terlipressin, we go to the
It's like a
midodrine.
vasopressor, yeah, in the tablet form.
That's it, nothing else. In acute liver failure, I don't think so. Midodrine is having any role or anybody is using it. At least I am not using it.
Sir, any role of plaques in Wilson's disease?
Dr. Akila?
Wilson's there's a class-wide recommendation for plasmapheresis and Wilson's disease, actually, Wilson's-induced ALF. So it can be done definitely.
And any role of GCSF in patient for ALF who are not candidate for liver transplant? Have you used any experience? The question is from Dr. Babu to everyone.
We don't have any experience in its use actually, but ALF, I do not know if there is any evidence, but ACLF, there's a lot of evidence coming up, especially in patients with HBV-induced ACLF, more so in the Asian centers. One from China and one from India also have shown some evidence in the use of GCSF and ACLF, but I'm not sure if there is any role in ALF. I mean, any studies have been done in ALF, I'm not aware.
So we have used a lot of GCSF of late for HBV failures, and it's very early to say whether it makes a difference or not. I'll ask me the same question in 2 years' time. I might be able to give you a better idea. Coming back to your question of midodrine, in my part of the world, it is a drug of geriatric ward. This is how we call it. So you will get this classical patient who will be on noradrenaline of 0.01. And every time you stop that, the blood pressure goes to 60, and you start it, it goes to 80. These are the patients who need midodrine.
Yes.
The biggest problem with midodrine, you must realize is, as Dr. Goel said, you send them to the ward on tablets, that's fine. But after 72 hours, you get a tachyphylaxis to that drug. But it's great for us as intensivists because by the time they are in the ward, so it's not your problem anymore. So it's okay, isn't it? So yeah, we do use it, but it's a drug for geriatric patients in our place.
Sir, any role of thrombopoietin analog in thrombocytopenia in ALF, sir, before transplantation?
Absolutely none whatsoever. I don't know if people will agree or disagree to it.
Dr. Ravi, can I ask one question to you?
Yeah.
The dose and the regime of GCSF, what you're using?
As I said to you, boss, the doses are decided by the nurse. We just prescribe it. I don't know. I will let you know in a text what is the dose. I genuinely don't know. We just prescribe it. And to be honest, because of the dynamics of GCSF, it is a 3-specialty decision. So it is decided between the intensivist, the standalone hepatologist, and the hematologist. It is not a single man decision. So there is a protocol, but I will look it up and I'll send it to you if you need to.
Sir, I think we have no more questions left, and with the interest of time, I would like to conclude the session. And before concluding, sir, just your one opinion on message to our all new trainees and fellow students, sir. Ravi, sir, anything you'd like to tell them?
Well, if you're talking clinical, then I'll say that if you get a patient of liver failure at 2 a.m. In the morning on your shift, don't complicate things. Just give volume, oxygen, and antibiotics, and let time take its own course. You know? Sometimes you just have to step back and let time work. don't make it complicated. It is when you make complicated things go wrong, is my view. If you're talking about exam, most of the things in my talk were at some point related to an exam. So that is all I can say, really.
So particularly during the EDIC exam, sir, because you are the examiner. So what message, sir, you would like to give to our exam going students?
Well, that's a very generic question, isn't it? I'm not going to go.
Some of the students are going for EDIC exam also. So if you can highlight some of the important aspects.
But this whole talk is about livers. It's not about the EDIC exam, isn't it? That's a talk itself. So let's not talk about that.
I would like to ask another thing to you. There are many trainees, and many of them are looking to go to United Kingdom for career enhancement, maybe further training or maybe a job prospect. How they should proceed, or what is your take on
that? The system is opening up massively of late, sir. If you look at it, there is a big recruitment drive, and I think it will carry on. However, I always say this to young trainees who have young families, that the grass is always greener on the other side. It is not as good and soft as it used to be once upon a time. The resources are constrained, the working conditions are difficult, and it is not the same what it used to. You will get the training, don't get me wrong. I don't think you can match the training curriculum and the training standards, but you have to look at the whole package. In terms of whole package, at this point, if I was in this situation today, when I came to this country 22 years ago, would I have considered it? The answer is probably no. I didn't sell it well, did I?
Govind sir, what is your one message to our trainees, sir, from your angle?
So my take on is just work as you should be, work honestly, hard work, and there is no shortcut to hard work.
Absolutely. And
Dr. Akila?
And I'm not a full-time intensivist. I do part-time theater and part-time ICU, unlike the other two people. I think it is a fascinating field. You need a lot of perseverance to continue. Just keep up the perseverance.
Dr. Divya, if you are available.
Critical care requires a lot of hard work, a lot of precision. So I think we're on the right foot.
Thank you. So, sir, with this, we are concluding the today's meeting, and it's definitely I thanks all the panelists and particularly our speaker, Dr. Ravi sir, for enlightening us today about the acute liver failure. And I think if sir is okay, we can have more and more sessions in the future also. In fact, with all of us and all of you, from my best of luck and best wishes to all of you, sir, from Apollo Hospital, Mumbai, sir.
Thanks very much. Thank you.
Gunnar, next topic, can you just highlight what is your next topic? And
yeah, yes, it's on the tropical infection, sir. I'll send you all the invitation by WhatsApp. Thank you, sir.
Sure. Thanks.
Thanks.
Thank you, sir. Good night.
Thank you, sir. Thanks.